Thank you very much, Prof. Coleman. Thank you everyone for coming. I'm sorry to intrude on the more important stem cell-based therapy talks and bore you with a topic of acute lymphoblastic leukemia in a very small group of patients and very tiny patients in general. The treatment of childhood ALL in general has improved very much for childhood diseases so that we actually looking even in the Malaysia-Singapore study group, which we belong to, we're looking at about 80% event-free survival compared to what David Ritchie and Richard Larson presented that day. Our results actually are much better in general. The prognostic factors are still there, like the NCI risk factors of age and white cell count. It's still statistically important, but unfortunately, it is not very useful for us in general to actually use for risk stratification. For example, the difference between our worst group and best group, about 40% of our patients are considered high risk using age and white cell count. The difference in event-free survival is barely 15%. Most of the relapses are still in the NCI low risk, and that is not very useful for us to tailor therapy in general. The Malaysia-Singapore group has embarked in 2002 using the 2003 criteria, which is using minimal residual disease guided therapy. So this gives us ability to measure the response of treatment to ALL to early part of therapy, and by knowing how good the patient performed, we adjusted the intensity of therapy. And this is the results that we have. Even our high-risk group, which accounted for 18 to 19% of the patients, has probably better event-free survival than the adults with ALL, which is rather unfortunate at this time. In teenagers, we collaborated a bit with our adult colleagues, and we took a few teenagers and young adults in our side. Even in the young adults that we have treated in the pediatric department did considerably better than, say, the hyper-CVAD or the GMOL type of therapy. And we are trying to convince our adult colleagues to really try to use the pediatric-based ALL therapy as part of the treatment. The Chinese famous Sun Tzu Art of War actually says in Chinese words, which I'm not very good at, is basically you need to know yourself, you need to know your enemy, and then you can win the 100 battles that you have. So in treating children, or rather any patient with cancer, if you know what are the prognostic factors, what are the chances of cure, and what are the toxicity of therapy, if you know that very well when you start, that's, I think, the important part in general. Unfortunately, we are not using much of the technology that we have learned over the years, like using minimal residual disease at this current time in adult leukemia. So there are a lot of factors that are important that we know a little bit about using leukemia genetics, like Philadelphia positive ALL, hyperdiploid ALL. We don't know much about host genetics in general. Most of us ignore it, although all of us know that each of us behave differently when exposed to different drugs. For example, after a mug of beer, I sing karaoke much louder than anyone else, and that shows the metabolism of each person differs. And there are other issues like tumor microenvironment, supportive care, and all that. So these factors are important, and we need to know them as if we want to treat and improve the treatment for children with cancer. This was the unfortunately, to really start off, the adults get a loaded dice. You all have worse patients up front. Even back in 1998, when Pui reviewed the data on leukemia factors, BCR-ABL, which have higher risk, is much more common in adults, accounting to about a quarter of your patients, but only about maybe 4% in the MASPOR trial in general. So you have the worst groups, you have the better outcome groups like hyperdiploid ALL, and TEL-AML1 is also much rarer in adults. However, it is really known now that even for pediatric ALL, the number of unknown translocations with the whole genome sequencing technology available in WashU and what St. Jude people have done, there are increasingly more and more abnormality known for each of the genetic differences that's available. And this is Pui's review again in Journal of Clinical Oncology recently, and showing that most of the unknown, which was 20-odd%, now is only about 7% in general, and most genetic lesions are found in general. So for us, for example, in the MASPOR group, the Philadelphia positive ALL still remains dismal because this was prior to the use of the tyrosine kinase inhibitor in our treatment upfront. But poor prognostic factors like the old E2A PBX1 translocation 119 now emerge to be our best prognostic group already. So treatment is really the most important prognostic factor, and you need to really put effort in that treatment upfront to get the best results. However, the use of TKI itself in Philadelphia positive ALL have been covered very much by Richard Larson on Friday. The toxicity is more. You can add on imatinib to induction, but the toxic death rate has increased. We alone in NUH actually have 2 cases. One died, and then another case who had necrotizing enterocolitis that had also currently in ICU, when we actually have to use a combination of 4-drug induction and TKI itself. Whether L-asparagine, which we use a lot in pediatrics, interacts very much with the use of the TKI, we don't know. But I strongly believe that this, with the adults working very hard at this group of Philadelphia positive ALL, I think in probably the next 5 years or so, you will probably see the Philadelphia positive ALL emerging as the best prognostic group in adult ALL, because that's something that you have found the Achilles heel to actually treat this disease. However, just published last week in Nature by, again, the St. Jude group, the Philadelphia positive disease like ALL, like CML, is probably a stem cell disease. There's considerable clonal evolution, so you cannot really predict what the patient is going to do very well in general. So basically what happened is that the clonal evolution may occur if you select the environment using TKI alone, you will select the resistant clone. So using the TB type of treatment, tuberculosis type of treatment, you have to use combination therapy upfront to deplete the stem cell clone, as well as trying to treat the leukemia if you want to cure the patients. So for me, I believe that stem cell transplant will still probably be an important element in management of BCR-ABL positive ALL in the short future. The St. Jude group also has published the data on looking at the DNA aberrations in childhood ALL, and you can find that aberrations like chromosome 4, 10, 17, 18 are constantly amplified or duplicated. And these are the good prognosis hyperdeployed group. And in addition, they also found the presence of, in BCR-ABL positive ALL, there is this deletion known as the ECROS deletion in patients. So ALL itself, BCR-ABL, we all know, is insufficient to transform to make leukemia. So you can make ALL or AML depending on the fusion transcript. And even if it's a P210, you can have a lymphoid transformation. But the second hit itself is really to transform into lymphoid, you must have a differentiation block. And the ECROS gene is important in the differentiation of B lineage. The deletion of this ECROS gene is important for the transformation of B lineage ALL. BCR-ABL positive B lineage ALL. And this is prognostically important in the target study, which the collaboration between St. Jude and the COG group, ECROS deleted patients do poorer in all the cases, inclusive of those that do not have Philadelphia positive ALL. And that emerged to be one of the new prognostic factors that can be done. However, the ECROS deletion is quite difficult to apply because it is a DNA deletion and it is quite a large gene, and there are various groups trying to address this issue. The Jemima group have also shown that in Philadelphia positive ALL, the presence of ECROS deletion actually worsened the outcome as well. So moving forward, in pediatric ALL itself, we found that patients with Down syndrome don't do so well. They don't have good prognostic factors like hyperdiploid ALL or TEL-AML1, and they can tolerate treatment poorly. Although in our numbers, in MASPOR, we only have 6 cases out of 556 patients. It is in other groups shown to be a bad prognostic factor. And it was interesting that the St. Jude group again found the presence of this CRLF2 deletion and CHEK2 mutation that was present a lot in Down syndrome, and patients with poorer outcome. In the UCAL group, they have actually looked at this. These group of patients perform more as an intermediate risk in terms of prognosis as more data comes out about this group. Dario Campana and Elaine Constant-Smith, again from St. Jude, has found that a new group of T-cell ALL that has poorer outcome. This T-cell ALL, like the CML group, is probably a stem cell disease. It not only has T-cell features, like for example, CD3 is upregulated, CD5 is there, but it has absence of CD1A and presence of myeloid expression like CD13, CD11, for example. It was actually quite a clever technique that Dario and Elaine actually looked at. I actually worked in St. Jude in 1999 using gene expression profiling. Subsequently, what happened from the data, Dario and Elaine was able to actually line up doing a virtual immunophenotyping by looking at the expression of CD markers on leukemia cells. And they found that in this ETP group, this is using flow, however, to quantitate the amount of protein. CD3 is highly expressed, like in all T cells, but the CD4 and 8 are actually not expressed in this group of ETP, so they are not so mature. CD10 is usually negative. Again, this when I was training, when you are T cell and CD10, you don't do so well. They have all these stem cell markers like CD117 and 133, and presence of certain myeloid markers. So this new group has a poorer outcome, have high MRD after treatment compared to other patients, and have poorer survival outcome even in St. Jude, with only 22% event-free survival compared to 69%. So this new group of ETP ALL is probably interesting to look at and see how to explore the prognosis, whether they need transplant upfront or not. And finally, the St. Jude group recently published in New England that you can omit cranial radiotherapy in children with ALL in all patients, but I would hazard a guess that the CNS3 patients, however, in that group, they can be salvaged. They only have event-free survival about 50-odd% without radiotherapy. They can actually, it's best to, at the current time, give radiotherapy. St. Jude Total 16 is now giving intensified intrathecal chemotherapy by giving more ITs twice a week, like the lymphoma protocol at this current time. But the number of ITs that we give in childhood ALL is much more. We have in our best group about 13 to 15 intrathecals. In the St. Jude protocol, in NUH protocol, we have 20 ITs. And then for the high-risk patients, we go up to about 30 ITs compared to 8 to 10 in adult protocols. So there's considerable amount of work. But as you treat the medullary component very well, I think you will see increased CNS relapses, and you need to treat both compartments. I think that part is important. Moving forward, in seeing young adults and adolescents see this problem of avascular necrosis of the hip. In patients that are developing like this patient who presented actually with sarcomatous presentation of ALL with bony involvement, he actually developed acute vascular necrosis with treatment. St. Jude investigators again found that these patients with severe osteonecrosis of the head of the femur, the frequency starts at about 6 months into treatment, when they MRI scan everybody asymptomatic or otherwise in treatment protocol. Patients who are more than 10 years of age, like this boy, have much higher risk of developing avascular necrosis in general. And the patients with receive higher intensity treatment with more dexamethasone have this effect. So the use of dexamethasone poorer outcome in terms of toxicity. It is because the level of dexamethasone in teenagers is much higher than in adults, in children for that dose of therapy. So in our new MESPOR 2010 study, we capped the dose of dexamethasone in our patients in general. So you find the people that are at risk. The COG group use discontinuous steroids instead of using for 1 month. They use it for 1 week and alternated. Dexamethasone, though more effective, is worse. And the St. Jude group again found certain genetic polymorphism that may be associated with this poorer outcome. Moving forward, there is apparently ethnic differences in outcome for childhood ALL noted by the COG group and the St. Jude group now. We have very good event-free survival, as I showed you earlier, about 80% event-free survival. And our treatment is only 1/3 the intensity delivered in St. Jude Children's Research Hospital. And yet we get 80% outcome, which is really not very far from that from St. Jude in general or in Germany for the BFM group. So in St. Jude, the Asians have 100% event-free survival in about 20 to 30 patients in the report. So I think we have a group of patients that do well. Is this a genetic factor, or is it that it is more a cultural factor that we face, and that has recently been addressed in general? But if you look at the solid tumor by survival, the Asians don't do better. So the whites do better in general in the SEER data. So is it a genetic factor or is it a compliance issue? Our parents, Asian parents, as most of you are Asians, are obsessive compulsive. I tasked this patient to photograph, he's a teenager, to photograph every night his 6-mercaptopurine using his handphone. Mom bought him a new iPhone 4 and he promised to do it. And he has been faithfully taking photo, and we download it to make sure that he takes his medicine every day. That's the compliance that you see. And it's just reported by Smita Bhatia in COG protocol in the recent abstract that patients, the real problem is adherence. Latinos have worse outcome because they have poorer adherence to therapy than other groups like the whites, for example. If you are a single mother, which is very common in the United States, and poorer income, you actually do poorer. So I think it is because of our parents and the mothers, especially among Asians, that are so obsessive compulsive about education and taking medicine that makes a difference for us. And again, published last week in Nature, by the St. Jude group. As you can see that the St. Jude group, I don't know, they have so much things that they have published over the last 2 years that I seem to be presenting like a faculty from St. Jude, talking all about St. Jude treatment. Anyway, the St. Jude group did analysis of about 23 PET diagnostic and PET bone marrow relapse to find what are the changes. We all know that in initial diagnosis of ALL, patients can be treated, but when they relapse, they do very poorly. So this mutation of this CRAB mutation has been found to be in some of the patients at relapse, and they affect the glucocorticoid response for the patients, and this may actually explain why certain patients with CRAB mutation do poorly because they alter the glucocorticoid responsive genes. So in bridging the gap, now we have done technology, morphology, flow cytometry, cytogenetics that are at least 30 to 40 years old. Oncogene fusion is starting to come into the protocol, but a lot of our adult doctors don't use it other than to do, say, BCR-ABL to know the words. MRD is consistently not applied in most patients, and that is really one of the things that you need to know what to do, and gene expression profiling and other genetic abnormalities will come along. I love to travel. All of us need a map and the knowledge in the internet. Buy a Lonely Planet before you travel to Myanmar, like to see this golden rock that you need to climb for 30 minutes and sit in a horrible truck like a construction worker, 80 people in a truck, and then you sway along. that is the knowledge that you need before you go and treat patients with leukemia. I think we have to apply and bridge this gap and apply this technology available. And that's the challenge, that we have to learn this and apply this along the way. Thank you very much for your attention.